Welcome, everybody. We will just give just a few more seconds for folks to make it into the webinar session, and we'll start with just an opening introduction and overview, and we'll get started. So let's just give it maybe another 20 seconds or so. All right, great. Well, thank you all so much for being with us today. My name is Marvell Adams Jr. I serve as CEO of Caregiver Action Network, which is the nation's leading family caregiver support not-for-profit, where we provide support, services, resources, and education, just like today's session, to family caregivers across the country and beyond. Just really want to welcome you today to our session about daily management to sustainable care, long-acting medication system barriers, and caregiver relief. And particularly excited because of one of our focal points today around mental health and the importance of this type of approach. But what I'll also share with you is that I'm not just the CEO of Caregiver Action Network, but I am also a former caregiver, a caregiving youth for my mom in my teens, as well as a caregiver, long distance caregiver for both my mom and brother in the latter stages of their life, and not to be outdone, as well as the parent of 3 kids that were born premature that needed special approach and attention. But be that as it may, I'm also a type 2 diabetic. And so long-acting medication and injectables is actually something that's impacted my life hugely in a positive way. So just really glad for today's conversation. And before I turn it over to Chance Browning, our Chief Operating Officer, I just want to give a great, a huge thank you to our friends at Teva Pharmaceuticals that have been just such a long-term partner for us as we do outreach and education to caregivers on a whole host of topics. And so much appreciation to them for supporting today's webinar. Chance, I'll turn it over to you.
Sure. Thanks, Marvell. Appreciate everyone joining us here today for this important conversation. We're going to do a quick round of introductions just so that you have perspective on each of our sort of lived experiences and where we're coming to this conversation from. I can tell you, similar to what Marvell described with his firsthand lived experience, I've navigated LAIs, long-acting injectables, long-acting medication, as part of my experience from the patient point of view, particularly through the lens of PrEP as a means for HIV prevention. And so definitely the lens with which I'll be approaching some of these questions and leading some of these conversations. I do want to allow each of our panelists to introduce themselves and share a little bit more about their personal lived experience, but also some of the community work that they're doing. I will also add, as Marvell described, I'm a long-distance caregiver for both my mom and my grandmother, and so the intersection of caregiving themes is very prominent in all of our lives as we approach this work. So I want to start with Dr. Carolyn Reggoratre and give her an opportunity to introduce herself, talk about her specialty area, as well as we go around and do these introductions. Carolyn?
Hello, everyone. My name is Dr. Carolyn Reggoratre, and I'm the Associate Medical Director out at Pecan Valley Center, which is a community mental health center west and southwest of Fort Worth. I cover about 4,500 square miles. I'm the only full-time psychiatrist for about 6 counties. We do have about 6 extended providers and 4 part-time physicians as well. But I run the ACT team, the first episode psychosis team. I'm also an assistant professor at UT Southwestern, where I help train residents in their rural track for psychiatrists. I'm on NAMI's Scientific Advisory Council, and I am also on National Council's Medical Director Institute. So my areas of expertise are rural community psychiatry, psychosis, serious mental illness, comorbid substance use disorders, homeless psychiatry, all the things. And I'm very excited to be with you here today because I am both an administrator, an advocate, and a clinician. So I sit in this very office with families every week and discuss these very issues. I was an early adopter for long-acting medications, and I'm a big advocate for them. And what I know is that when we get families involved and families start having access to information, they really make a big difference in what gets prescribed and what gets chosen with their loved ones. So I'm so excited to be here today because when families get involved, things happen.
Thank you. That's really important. As Nicole mentioned in the chat, please, for those who are joining us today live, drop into the chat where you're joining us from and who you help care for, or the lens at which you're approaching care. Definitely helps us to give examples that may be most relevant to you given your location. Lisa, I want to turn it over to you to introduce yourself and also talk about some of the important community work that you're doing.
Thank you so much. It's my pleasure to be here. My name is Lisa Bright. I am the mother, founder, and CEO of the Will Bright Foundation. We lost our son, Will, to a heroin overdose in 2012. We started our nonprofit with the goal of helping people where Will struggled the most, which was his next step in life. So we have run a facility called Restoration Springs in rural West Alabama, and we provide wraparound services like housing and transportation and recovery to workforce training. So our main goal is to get our guys employed, get them back into the real world, get their driver's license, all the barriers that have kept them from being successful in their recovery. It's our pleasure to serve people as a distant caregiver because we run the foundation. I may not know each and every person personally that is under our care, but how important we have realized it is to be able to have long-acting injectable medication for our guys so they can stay at work all day long and be able to function and not have to go to a clinic and be more tied down that way. So grateful to be on this panel and look forward to some good questions and hopefully some good answers.
Excellent. Thank you, Lisa. Maria, would love to hear a little bit more about your story and sort of some of the important community organizing that you're doing. Oh, you're muted.
Hi, everyone. My name is Maria Case. I'm out here in Orange County, California. Our journey began with my mother having schizophrenia symptoms about 14 years ago. We navigated schizophrenia for about 10 years, not really knowing exactly what was going on. We hid behind closed doors because in our culture as a Latina, we believe that schizophrenia is witchcraft and medicine is an enemy. And being in our own journey, we realized that it was quite the opposite with education. So I have made it my life passion to advocate for everyone, make inclusive spaces. I founded Compassion, who is a nonprofit organization. We partner with providers that offer free consultations in Spanish and English, so that barrier is no longer there and people get the attention that they need. We didn't find out about long-lasting injectables for about 5 years. In fact, we didn't even know it was even something that was available. So I'm really grateful to be here with you guys. Thank you for having me.
Thanks, Maria. Christy, we'll wrap it up over with you. If you could share a little bit about your own personal story and some of the important community work that you're doing in Virginia.
Yeah, so hi everyone, I'm Christy Stonehill. I came into this world as a caregiver of my daughter who had a psychotic break very early in life, right when she was supposed to be starting her life, and everything kind of fell apart, which threw our whole family into pretty much chaos. So as a caregiver, I learned real fast that, I was going to have to learn how to advocate and figure out what all of this meant for her and what it meant for our family. And through that, I ended up getting real passionate about helping others who are also caregivers and helping them learn how to navigate the systems and advocate for their loved ones and just help the community out in any which way I can.
Excellent. Thanks, Christy. As we dig into things, and folks, please drop your questions into the chat. We want this to be an ongoing conversation, and we have some time reserved at the end to answer some of those questions that you've brought up. My colleague Nicole and others are helping to manage the chat and drop some of the tools and resources and information into the chat so that you can easily access that. But Dr. Reggoratre, if we can start with you and just do a level set. I've seen a couple of comments in the chat already around when we talk about long-acting medications, when we talk about sort of the shared decision making that patients and families have to do in deciding on a therapeutic approach. Can you just help us level set what we're talking about here, what conditions long-acting medication covers, and I also want to dig into some of the language around it because I know there's easy confusion there.
Absolutely. Well, when we're talking about long-acting medications that are available in the mental health space, it's kind of important, I think, to go back and think about our history around medications and forced medications, things like that in general. Long-acting medications as a class of any medication were really developed in the 60s. The first long-acting injectable medicine available here was in 1972, and that was Prolix and Decanoate. So these are not new medicines. Around that same time in the UK, they were also developing novel long-acting birth control. So the two medicines that were long-acting in the beginning were designed to control the things that we wanted to control: women's reproductive health, fertility, and madness, right? Mental health issues. Both of these things are very helpful for patients, but because the beginning felt somewhat like control, I think we see that in women's reproductive health, those medicines have been celebrated. We heard one of our panelists report being on a long-acting medicine for diabetes. We don't often hear it called that, right? If someone's on a shot for diabetes, they usually will just say that. There's no stigma. In the mental health space, more than any other healthcare space, we have continued to carry the stigma and the shame of unethical, burdensome, forced treatments in the last few centuries. So we're talking about things that occurred to people in the early 20th and the late 19th century, like dunking people, forcing people to be in asylums, pulling people's teeth, lobotomies. There are things that have occurred in psychiatry that were horrible to people experiencing psychosis, substance use disorders, dementia, intellectual disorders. And as a result, many people are still very suspect about mental health treatment. And so no other field do you see longer dosing intervals of medication seen with any suspicion. So if we want to be controlled in our blood sugars, we would welcome a longer acting diabetes medicine. If we don't wish to be pregnant, we would welcome a longer dosing interval in a contraceptive. But in mental health, when we have longer dosing intervals, there continues to be a recoil. And this is not just among patients. This is sometimes among us as providers about worrying that we're trying to control people too much. And so the very first thing I'd like to say is that mental health disorders and substance use disorders are brain illnesses. That has been established again and again in the science. And so these are conditions that we try to alleviate and treat. We are not seeking to control people with medication treatment. In fact, the vast majority of my patients who are on these medicines come back to me and say, "Oh, this is so wonderful. I just saw one actually just 10 minutes ago." And he said, "You know, that shot really helps. It really makes those voices go away." And I said, "Yes, that's nice." And he said, "That's all I want. I'll do that." So when we're having conversations around medicines, we've switched language away from long-acting injectable, which is equivalent to long-acting medicine. Part of that is to reduce the kind of any type of intimidation around the idea of a shot. But all of these medicines that we're talking about today, whether they're for things like psychosis and schizophrenia or bipolar, or if they're treatments for opioid use disorder or alcohol use disorder, like we have some long-acting medicines for those too, they are all coming in an injectable form. Some of the injections are going into the muscle, just like a flu shot. Others are going into the fat, either on the back of the arm or the stomach, kind of like a diabetes medicine would. And these are kind of tried and true standard ways of administering medication. There's nothing too different there. The dosing interval is just increased because the medicines kind of dissolve at a consistent rate over time, allowing there to be just a very steady blood level. And so sometimes this is also advantageous because you skip the liver, you're skipping the GI tract completely. If people have stomach issues or things like that, you don't have to worry about that. And so it's a very easy, convenient way to dose medication, but it's also been shown with increased adherence to actually get better outcomes than the exact same medicine given in a pill every day. So when we talk about long-acting medicines, one of the things I always say is it's not just about convenience. There are now studies, like one in 2017, showing that people with schizophrenia in particular who are on long-acting medicines actually live longer than people who are not taking medicine at all or are taking pills. I mean, that's a big deal. So this isn't just about convenience or control. It really is about providing better options for a lot of our patients.
That's really, really important context. Thank you for sharing. Can you talk to us a little bit about what the caregiver role in that looks like?
Oh, yeah.
Obviously, you may be seeing patients from kind of across the spectrum in terms of age and scenarios, but can you add some color into what the caregiver role looks like in navigating this, whether that's through access or through the adherence piece?
Everybody has a different experience, but it's incredibly difficult. And I would love to share the floor with people who actually have that lived experience. But what I see in my office are oftentimes family members coming in absolute despair. Because, for example, the illness of schizophrenia or the illness of bipolar or the illness of opioid addiction or alcohol addiction often come with a symptom that we call anosognosia, which just means you don't believe you're sick. So that is a core feature of many mental health disorders, is that people come to us and they will tell us, I don't need any medicine because I'm not sick. And their family members are literally watching them dying in front of them. They are terrified. They are doing everything they can to try to keep them alive and well, and they're getting burned out very quickly. They're not just getting burned out in their own emotional health, they are at risk physically because people can have violent episodes, whether they're dealing with a psychotic issue, a manic issue, a drug intoxication episode. Sometimes they're also dealing with the fear of someone who is suicidal, and their moods are going up and down. I mean, so these are not minor issues to be living with a person in the house. And so when they come to us, one of the things they're saying is it is a daily battle to try to fight that same conversation every day. So every day we're having the same conversation. I don't think I should have to take this. Please take it. I don't think I should have to. And so they're going back and forth and back and forth. Even if they're in the office with me saying, yes, yes, I'll do that, they may have second thoughts when they get back home. And so it becomes a major power struggle, which then saps energy away from the caregiver's ability to have a real connected relationship with the person they love. Mm. And also sometimes it's affecting their own health. They have to miss work. I have so many caregivers who come in and say, I do not have any more days off of work that I can come in for visits, that I can take them to the ER. And they're worried about losing their jobs, their livelihood. This really affects families. So being able to have that conversation once a month, once every 2 months, once every 3 months, 6 weeks, or even 6 months, that's a huge win for families that I have seen.
Thank you. That's really important context, and thank you for kind of setting the stage for this. Christy, I see you nodding, so I want to take it over to you and get some further context on your journey to long-acting medication. Maria, I want to come to you as well. I heard shot referenced as sort of a language alternative, so I would be curious to hear, as you're thinking of this not only through your personal experiences, but some of the community engagement that you're doing as well. So Christy, can you tell me a little bit about like how you got to that long-acting medication in your scenario?
Right. So when my daughter first got ill and she was taken in on an ECO, obviously that's involuntary. So the first thing I did was sort of calling around and seeing like, what can I do? How can I help her? I had no idea what was going on. I got a hold of a doctor at Johns Hopkins, which is about an hour and a half from me in Baltimore. And they said, look, you're not going to get your daughter to come here. She's not going to agree to it, but call them back and tell them to give her a long-acting medication. I had no idea what that was. It was the first time I had heard it in my life. I scribbled it down on a piece of paper. I remember even forgetting what I was saying when I was talking to the case manager and saying long acting. And they were like, yes, injection. And so we went back and forth 2 or 3 times, and I basically walked away feeling like that the doctor thought I was asking for some type of luxury item, and I didn't understand it at the time. And that's when I realized that, obviously we know that care doesn't look the same, not only state to state, but region to region. So things are a lot different in people's areas. And I realize that. But for my area, there is a huge hesitation in giving these long acting injections. And I don't really have a good reason why. And that's kind of a rabbit hole that I decided to go down and say, why is this? Because as a caregiver, it buys us more time. We don't know, let's say it's the first break, we don't know when that person comes out if they are going to ever have insight. We don't know that. And we're already scrambling, And I mean, I think a lot of people don't understand from a caregiver's perspective that you are not only grieving and mourning somebody that is no longer there, but they're physically present, but they're not the same person anymore. But you're being thrown into this whole system of care. And guess what? Oftentimes you don't have a voice because you don't have rights. So here you are trying to navigate all of this. I mean, my daughter ended up getting her injection. When she was released, she was also given a prescription. Do you know what she did with the prescription pills? She flushed them down the toilet. So, I mean, I knew that that's how that was going to go. I was thankful. I had the exact date she got that injection, and I knew, okay, Christy, you have 2.5, 3 weeks to figure something out now, because that gave me that peace of mind. And I'll tell you, I don't understand from a provider perspective why there is a hesitation at all. I don't get it. I understand about insurance stuff. I understand about, if somebody's there voluntarily and they just don't want to do it, I get it. But it has so many benefits to it all around. I mean, we talk about things as simple as going on vacation. If my daughter's going with me, she's carrying a boatload of medications to go on that vacation. And then let's say she has to take it at 4 p.m., whatever I'm doing, I've got to stop and make sure she gets that medication. Whereas when you have an injection, we're good. Another thing is going on vacation without your loved one. Leaving them at home knowing that they've had that injection is it's a peace of mind that you don't get from taking those pills. From a community, I'll wrap this up, but I'm so passionate about this, but from a community perspective, I will say that I have a friend that always says, what you don't know is what you don't know, right? Which is common sense. But when it comes to caregiving, we cannot effectively advocate for things that we don't know about. We have to have that knowledge. We have to understand what we're saying to these providers. This is why I need you to consider this if you're in an area that's not considering it. This is not, like she said, a convenience. This is not a luxury item. This is a replacement to something that I know I'm not going to be able to do once that person's back in my care. And we know that it reduces suicide. We know that it helps in so many ways, but yet it's still not talked about enough. And I don't get it, but I'm off my soapbox now.
That's really valuable perspective. Maria, I want to come over to you and hear more about your journey to a long-acting medication with your mom, and also, revisit kind of that language component that is so key when we're talking about and framing some of these approaches.
Yes, absolutely. So our experience with a long-lasting injection was my mom had a psychotic break, and she had to be taken in on 5150. And it was really hard at the time because we didn't even know about anagnosia like at all. We didn't know anything. We weren't educated. At the time, they gave her, medication for 10 days when she was held on a 5150. She went home, and I finally stepped in because she didn't speak the language. So she couldn't communicate with the doctor. So she didn't really know what was going on. So when I stepped in, I asked if there was anything else that we could do because she wasn't believing that she was sick. The biggest barrier was giving her the medication where she didn't think she needed it. She thought she was completely fine. So then they did finally tell us about Sustena, and we put her on it, and it was great. Once a month we would go, and that we didn't have to worry about trying to give it to her every night and having that, constant battle with her. So she did really well. And, I think the biggest barrier right now in the work that we do in the community is lack of education overall with mental health in different cultures, especially in our Latino culture. What is believed, witchcraft is the reason why people have schizophrenia. Medicine is the enemy. It's really been really hard to reach out to the community. What has been very successful for us is teaming up with schools that already have, the parents that are getting together for mental health and just bringing awareness. My father and I speak very openly about what we go through, what is out there, what type of medications, just education in general with NAMI and what we offer as well as free consultations, because the barrier of finding a doctor that speaks our language has been very difficult. In the last 14 years that my mom has been dealing with her diagnosis, she's had one doctor that spoke Spanish, and Spanish was not his first language. And that was very difficult because they didn't really understand the culture, and feeling safe is so important. To meet people where they're at is so important, because it's scary, especially if they've never heard of anything like this. They think it's foreign to them. So meeting people where they're at has been very impactful for us to reach families and get them the support that they need.
Thank you. That's really important insight and context for so many that are no doubt on joining us today or will be viewing this. Lisa, I'm curious with the work that you're doing in the community, introducing the idea of long-acting medications, long-acting injectables. What does that look like? What does your approach include, particularly in those rural areas that I know both you and Dr. Reggoratre referred to?
Yes. So when we started our foundation and started our transitional living facility, we didn't do any kind of MATs, any kind of medical assisted treatment, because we didn't have a clinician. We're a faith-based recovery center and not part of a greater clinical staff. So we started that way, and we quickly realized there's a lot of people that we could be serving in a better capacity. And how could we do that where we would not have to have the clinician on staff? So we just are utilizing other medical facilities and clinics that we can do the long acting injectables, which, because of where we're located, transportation to a place that would actually service any kind of MAT would be almost an hour's drive one way. So trying to provide that wraparound service of transportation, that was a huge obstacle. So for us to be able to add the long-acting injectables onto our programming, it was wonderful. So it's allowed people that want to, and it is definitely a want to part of our programming, be a part of what we do at Restoration Springs, but yet they need medical assisted treatment. So that was a big addition to us, and I'm grateful that now we can serve even more people. We don't have as many restrictions as we had before. So I hope that I think when you're in the space that we're in, we're not around a lot of medical people. So we're in recovery, we're in small groups, we're doing recovery trainings, that type of work. And you want to stay knowledgeable about what is available to your clientele that you're serving. So being able to be on something like this and hear more about different options for people that are in addiction recovery, I think it's going to be a win-win for us, and I hope for the people that are listening.
Thank you for sharing that. A piece of what you're touching on reminds me, Dr. Reggoratre, of what you've mentioned before about when and where and how some of your patients elect to access LAIs, whether it's in the office or through pharmacists. Can you talk a little bit more about what that range can look like?
Yes, and also just to take a step back and really to highlight what Lisa is saying, we know right now that, for example, Europe utilizes on average long-acting medicines for schizophrenia at a much higher rate, and so does Canada, than our system does. These are socialized systems of medicine, and they are using these drugs at a higher rate. So I think to get back to why aren't prescribers doing this? When we look at addiction, when we look at, for example, alcoholism, which affects a lot of Americans, millions of Americans, maybe 9% of everybody who meets criteria for a substance use disorder with alcohol, for a severe substance use disorder, would have any access to MAT, which is medication-assisted treatment at all. Of those people, only 2% are getting long-acting injectable forms. That's really low. And we just heard the obvious truth from Lisa that guess what? It's really hard to work when you're trying to deal with taking pills every day. When we talk about opioids, we're going back to the methadone clinic structure, which methadone is still a gold standard. It's a life-saving treatment for people addicted to opiates, but it is a total killer when you're talking about getting to a job every day. You have to line up. It's a huge stigma. You have to be observed and take it. And I mean, could we go to our jobs today if at 10 a.m. My local rural, we have like one methadone clinic, you get there at 10 a.m. Well, what job can you go to after 10 a.m.? So these were paradigms that kind of, I think, chased people away from wanting to be on any medicine, especially for a substance use disorder. And we're still dealing with some of that stigma today. So it's not just getting people to think about it, it's also getting providers to understand that something like Sublocade or Brixadi or Vivitrol, that these really should be more often incorporated into our practice and not like the last line of treatment. I always say a lot of providers are looking at long-acting medicines like they're seat warmers in a car, like that's a luxury feature. And they say, well, if someone's dying of hypothermia, well, then maybe then I would add the seat warmer and turn it on for them. Well, at that point, they're dead, guys. So we shouldn't save this. This isn't a luxury feature. This is a scientifically developed, really good way to get medication that's life-saving to people. I don't know why we would want to wait, especially with substance use disorders. As Lisa found out, these are deadly illnesses that we really should be taking seriously. And I think those of us in the provider world have been told in the mental health space, I really think join with your providers and make sure they know they matter, because our patients matter and so do we. We don't take up too much space when we ask for life-saving treatments. When I talk to my colleagues, the number one thing I hear is, well, that sounds expensive and that sounds a little invasive. That sounds like that's a little much, right? Why can't they just take their medicine? And the answer is, well, because we're dealing with mental health conditions that don't give us a lot of leeway for missing a pill every day. If you miss your medicine and you go and have a relapse, that could be it. If you miss your medicine and you have schizophrenia or bipolar and you have a major episode and you walk in front of a car, that's it. So I think these are serious illnesses that the flip side is when people are in recovery, they do amazing. They go out into the world and you do not know that these people have a mental health or a substance use condition. And so the other flip side is that I think we are living in a world that does not believe that people can recover from mental health and substance use disorders. And so if you heard nothing else today, please know hope for recovery is possible. And that's all we're trying to do is offer solutions earlier in illnesses that can provide that hope.
Thank you. I mean, I would add through the PrEP lens, I took an oral for 10 years. And once these LAMs were available, accessing them became the real barrier because of either my specialist didn't, wasn't urging me to, or there were certain sort of socioeconomic criteria that they were applying to the use cases. Christy and Maria, I want to go back to you to kind of add some color about how having your loved one on an LAM or an LAI benefited that day-to-day life and stress that so many caregivers are under when helping to support a loved one in these scenarios. Christy, I'll start with you.
Well, I think one of the biggest things, and we've touched base on this before, is that it becomes about the person. When I am carrying around a case and I'm trying to make sure that my daughter takes all of these medications at these point in times, it's really about the illness 24/7, right? And when we have this injection, it kind of takes all of that away. We're no longer just focused on, did you take this? Did I mess this up? Did we miss this time? We are actually able to just focus on like other things that are going on. And so that's one of the reasons that I advocate in the community for that, because it takes a huge emotional burden off of a caregiver when they can just kind of have some normalcy back to focusing on who this person is that they love so much in their life. And so, going back to one of the things that the doctor said is that I recently had someone in the community. Well, 2 years ago, we had a facility locally that absolutely refused to do a long-acting medication before the person left the hospital. This was or is a mother of two young children. And, the fear was she was in a really bad state of mind. We absolutely knew that she was not going to take the medication when she got out of the facility. She left the facility and she left. And she's been missing and presumed on the West Coast for 2 years now. There isn't a day that goes by that I don't think about her because I can't, and this is what I tell people in my community. I can't tell you, I don't have a magic wand. I can't tell you what the outcome's going to be. I don't know that if they get this injection, there's going to be this miraculous outcome. But what I do know is that there's a chance of something better. And so why not? Because it's the same medication that they're getting in the pill form. So why would we not do this? Because we know that a lot of these people do not want to be taking medications anyways, especially if they lack insight. So it just seems to me to be a no-brainer, especially if you're being held somewhere. And I don't understand it, but yeah.
Thank you. Maria, can you tell us a little bit about how that changed and transformed the lives of you and your family in caring for your mom?
Yes, absolutely. So for us, I believe it was a turning point. So during the time that my mom got introduced to it, she went through a psychotic break. She actually broke into our neighbor's house and said that they were in her house. She was trying to get into her house. And that's when we knew that we needed to take her to the hospital. And we actually had to call the enforcements to come and take my mom. It was a very difficult time because our family was not educated and my father didn't believe in medication. He believed that plants could, miraculously heal my mother. And it was a very difficult time because we were not on the same page. Education was a huge barrier in our family. But when I got involved, I did finally talk to her doctor, try to get a little bit more understanding and try to educate myself. And when we put her on the injection, when I say it was a turning point, it was because I didn't live with my mom. So my dad didn't believe that she needed the medicine. My mom didn't believe she was sick. So they weren't giving her the medication. So she was constantly not getting better. We didn't see like light at the end of the tunnel. But when she started taking the shot every month, I would have that conversation with my father where he didn't believe that my mom needed it, but they started seeing slowly her getting better and her coming back as a mother and a wife and, being able to have a regular relationship with us and her even knowing who we were because she lost touch of reality completely. She didn't even remember any of us. So I truly believe that it was a turning point for all of us to get education and really understand what was really happening and understanding like why she didn't believe she was sick. 'Cause we didn't know. We had no idea
Right.
what was going on. So yeah, that's
No,
our experience.
thank you. Thank you. And I mean, I think the real message here is understanding what your options are. Certainly, none of us are encouraging folks one way or the other, but rather raising awareness that these options exist for the patient and the family to engage in that shared decision making that makes sense for their circumstance. Lisa, I want to go back to you on a similar note in terms of the positive outcomes that you see in the lives of these individuals that you serve. Can you talk to us about what that looks like and how you've seen, LAMs make a significant difference in just their day-to-day management?
Absolutely. So we serve people from all over, from all different backgrounds, from all different ages. We have anywhere from a 25-year-old up to a 65-year-old. So there are different needs there. There are different expected outcomes from their perspective. So we have to look at all of them. I do want to piggyback off what we were speaking about earlier on I see that you put in the chat the non-opioid choices. One of the barriers for our guys is because they're typically coming to us with the shirts on their back, that's all they have, is the cost. They don't have insurance yet. They're getting a job and we're getting them employment that is good employment that has benefits and insurance in time, but you don't get it right out of the chute. So what we are trying to do with Voices for Non-Opioid Choices, which I sit on that board, we're based in Washington, is we are pushing legislation to get these drugs paid for. We got legislation passed in 2023 called the No Pain Act, which benefited people on Medicare. So 65 and plus saw a huge rise in drug addiction in that particular age demographic because they're getting all the hips replaced in the joints, and you're getting on medication, typically opioids, and you feel great until you don't feel great anymore. So trying to do things from long acting injectables to devices to other things that they'll cover an opioid, but they won't cover another option, which is pretty much what got us in this big predicament that we're in right now anyway. But trying to work through that, and I think it's got to come from the top. It's got to come from our Congress. It's got to filter down into through insurance. So we got the piece for Medicare covered, and now we're trying to extend what they cover under that. So they kind of want to keep it very limited. Now we're working on a piece for veterans through TRICARE. We have a huge amount of addiction in our veterans, and we want to be able to provide them the services that they so very well deserve. So there again, it could be a barrier if insurance is going to cover that or not, and TRICARE typically does not. And then eventually we want to get it all the way down to private pay. So I encourage anyone to go look on that website. It's nonopioidchoices.org. Thank you for putting it in the chat, where you can get educated on what your legislatures are doing, what's your congressmen and senators, where they stand. Are they joining groups like Voices for Non-Opioid Choices and trying to make a difference where people can actually afford to get these medications? They're great, but they're only great if you can afford to get them. So that's probably our biggest hurdle, is getting that expense covered however we can, so the person that is in our care is getting the best care that they can, where they can live a normal life and go to work and be successful and not have to line up, like Dr. Dre said, have to line up outside of a methadone clinic that's an hour away from us and have the stigma of, oh, they've gone to the drug clinic, they're a druggie. That's not what we want to present, and we can do better than that. And so that's my soapbox, and I will continue to be fighting. I'm in DC several times a year, just pushing. We've got to get these type medications covered by insurance.
And that chance, I remembered to follow back up. This is the perfect time to talk about what you were talking about as far as the healthcare team, and including pharmacists and specialty pharmacies, in that we are blessed to have a specialty pharmacy co-located where I work. And it's across the country. It's Genoa, but they do a lot for us with prescription, the PAP, which is prescription access, and also helping us with prior authorizations, even on patients who don't have insurance. They have been able to connect some of our patients to foundations. There are other pharmacy networks that are very helpful. And so if you ever have a question, sometimes reaching out to your local pharmacist directly, they sometimes have access to resources. There is, for example, an entire foundation just for people with schizophrenia that will sometimes cover, we've had them cover up to $1,000 of a deductible in these high deductible plans. I had never heard of it. It was our pharmacy that connected us to them. I find better results when I'm working with an actual, like, smaller owned pharmacy versus the big chains. I find that the big box stores and chains, although they have wonderful pharmacists working there, they are not going to take the time. If they get some sort of prior authorization, they're just kicking it back, and they tell the patient, oh, this isn't covered. I've seen them do that on like the 6-month shot, where they say, oh, this isn't covered on Medicaid. That's not true. It's actually just that it's 6 months of medicine, and that there's a price limit in Texas that it kicks out. So our other pharmacist said, no, this is just, I have to make a phone call, and he'll make it. So I think really working with local partners, pharmacists are an excellent resource. If you have a clinic, let's say someone in private practice, and they say, I'm happy to write for this, but I can't give it. No problem. You could go, many pharmacies are happy to do the injection as well, or they're happy to connect you to what they know about the prescription access program, and that may be submitting financials and other things like that, and the drug company will send the medicine. Even if it's a kit, if it's an injection kit, they will send it to them, and they can bring it in and have it administered there. So sometimes there are other options. It just takes, it's like moving mountains to find them.
Right. A little bit on that note, and Christy, I know you've brought this up before, so anyone feel free to jump in here, but like, are there specific, for caregivers who are navigating this and who are interested in exploring what LAM options may be available for their loved one. Are there specific questions they need to ask? Is there a specific way that they need to be pushing back, whether it's within the doctor's visit or whether that's when, a conversation with their insurance company? Any recommendations on that front?
I would say it really depends if what the pushback is. So just so people know, as far as an illness of schizophrenia or even bipolar with a psychotic episode, there should be no pushback from a payer on getting a long-acting injectable. So the American Psychiatric Association, especially their treatment guidelines for schizophrenia, schizoaffective disorder, state that any patient can have a long-acting medicine at any time in their illness if it's what they are asking for. And I would say by extension, their caregiver in the room. They are this is shared decision making, and they may have discussed it beforehand. They come in. So there should never be a reason. There's no stepped or tiered decision making from the standpoint of the American Psychiatric Association and from the standpoint of any payer I've seen. Sometimes they prefer one over another because of cost, and that's their preferred. And that is something that the clinician can work through and decide, okay, should I switch it or should I stick with their preferred, or do I need to make a case? When it comes to providers just flat out saying they don't want to do it, oftentimes you won't get a good answer out of them. Sometimes you're sitting there with the client and the client's just quiet because that's what it's like to be in psychosis. And they're saying, well, I can't do it if the patient doesn't want to do it. And I'm always a little befuddled by that, because when I tell people, okay, I think we're going to do a shot today, here are your options, they pick one and they do it. So I hear very often that patients refused, but no one was there to witness that refusal. Right. So I would just say, if you guys are getting stuck in a waiting room, ask to go in. Never stay in the waiting room. And any provider that says that you need to stay in the waiting room when someone has a psychotic illness, I'm not sure what they're doing, but they are trying to save time. Most likely, that's the only reason to do that. That's not the standard of care. You can go and ask that clinic to change providers. You could switch to a different provider, and you can call your insurance and say, if there's no one else in network, just tell them that you are not getting care that is the American Psychiatric Association's practice guidelines, because we have standards of care that we have to meet. Now, that doesn't mean we're going to bully people into doing something they don't feel comfortable with if they truly don't feel comfortable with it. But a lot of the excuses I hear are around providers feeling like it's a hassle more than anything else. They've got to provide the shot. They got to make the nurse do it. That's not your problem, in my opinion. We should be taking care of that. We should have systems of care that can accommodate people. And I think the entire thing, whether it's HIV PrEP, whether it's medications like these, whether it's opioid substance use, it's almost like the world is like, oh, you people again. We feel like you have created your own problems and you want us to fix them. Well, that's everything in healthcare. That's people who smoke and get lung cancer, but they're never treated that way. I've never seen that happen. That's diabetes, that's hypertension, that's everything. We would have to shut down all of healthcare if it was we only take perfect people. But there's something different about some of these illnesses, and I think sometimes we just have to be stigma busters. We have to go in with our truth that for me, my vocation, for you guys, your family members and loved ones are worth it. There is nothing inferior or broken about them. This is just a medical condition like anything else, and this is the United States of America in the 21st century. I think we can do complicated things. And my unpopular belief is that, quite frankly, maybe we don't need to save money all the time. Maybe we need to pay more. Because when we paid more for heart disease over the last 50 years, we reduced heart attacks, and we now have that. We have lowered that as a cause of death. And that took 5 to 6 decades of education, of providers talking to patients, of paying for things that worked. So I think we can do it with our mental health illnesses too, but we can't do it when we don't try.
Right. And I mean, from the patient perspective, I will say it was a stark difference in navigating this conversation with my primary care provider versus going to a LGBT clinic that specializes in this very different conversations. Christy, I know you've talked about the advocacy piece and any tips or tricks that you have found particularly effective as you work with both your daughter and your community.
I think from a community perspective, the biggest thing is don't stop trying. You know, we can be very respectful of the systems, the providers. And also, my second thing is don't walk away not knowing why, right? So, like, it's okay for a provider to say, I don't want to do this, but can you tell me why so I can understand it? And a lot of times when you find out those whys, you're able to kind of navigate it in a different way, right? And so, you know, going back to her point about like being in psychosis and being quiet, I remember people getting frustrated with me about being in the room with my daughter, just simply being there. And prior to my daughter's situation, I was never an outspoken person. All right. Her situation changed everything for me because I was like, I'm going to have to like go out there and speak. I don't know what else to do. And so me, you know, getting frustrated with me about being in that room and she's sitting there quiet. And I can tell that's the consensus. The consensus is, well, she's not speaking up. Either she's being controlled by this caregiver or she really doesn't want to be here doing this. Well, no, she doesn't want to be here. She's literally in the depths of psychosis. So, I mean, you know, we have to deal with that a lot as caregivers. And my biggest thing I tell people is don't give up, you know, be polite, be respectful. And, you know, we all have our things we're dealing with on both sides, but don't stop advocating. And in order to advocate, you have to have the knowledge, research the long acting medications, research what you need to be saying and asking for. So
That's really great context. Maria, anything you would add on your end, or Lisa? You're muted, Maria.
I would just say that the biggest thing that I've seen in my community and just in my mom is in our family has been education, just always allowing ourselves to educate ourselves and see what else is out there, what's new, what's going on, and just showing people that there is life. Like my mom is, you would never be able to tell that she has schizophrenia, but you saw her 2 months ago. She thought her name was Erica. Her name is not Erica, it's Daria. She didn't believe my dad was her husband. She didn't think I was her daughter, you know, months ago. And now she's fully back to herself. And I feel like that is something that everybody needs to know, that there is life with schizophrenia. And people just need to work together as a family. And that's exactly what I think is the most important thing that people need to know.
Thank you.
I-
Yeah, Lisa, go ahead.
I'll just tag on to the last thing is I think sharing your story. So when we're on Capitol Hill and we're going in and out of many congressional and Senate offices, it's sharing the story of what happened to Will, how Will got hooked onto opioids, which eventually led him to heroin, which eventually led to his death. They need to hear that. Your community needs to hear that because someone may be going through that very same thing with their child and it's the stigma of, oh, I'm just a bad parent. I lived with that for a long time and it's not true. And I think being the vocal person and sharing your story, which is really not my personality before Will died, but it is now, that helps people understand, possibly prevent something happening to them and their family. So just share, because someone else is already going through exactly what you're going through, and they may get something from what you're sharing and be able to help themselves or help others.
And just to follow up on that really quick, sharing your story is also healing for yourself, right?
Absolutely.
The more you share, and you know, I remember when I first started telling my story, I couldn't do it without choking up. And then by the end, now I can tell the story and I'm fine. But just like you, I wasn't outspoken. And I realized though, if we all just sit here and we close the blinds and we huddle in and we pretend this isn't happening, we hide it from the outside world, how do we ever make a change? How do we ever reduce stigma? How do we ever fix this problem? So that's when I was like, I gotta go. I gotta go tell the story to everyone who will listen. And I can't tell you the amount of people that have said, just talking to you and knowing that you have a story similar to mine has given me an ounce of hope. And that's what it's all about.
Absolutely. Thank you all. Nicole, I do want to invite you to come off and mute. And I know you've been monitoring the chat and there's been some lively discussions. Wanted to see if anything bubbles to the top that we wanted to pose to our panelists.
Yeah, I think there haven't been many questions that have come through. I think that the panelists have done a phenomenal job at navigating that. One thing that I wanted to make sure to mention as we wrap up is one of the things that we've been doing here at CAN is really ramping up our resources specific to mental health diagnoses. And so just at the end of last year, we were able to release a new resource for those caring for a loved one with schizophrenia and navigating HIPAA, which is oftentimes a big barrier and is key when we're talking about things that have been brought up like shared decision making. So I definitely encourage folks. I know that we've been putting lots and lots of things in the chat for resources, but please be sure to also check out caregiveraction.org for additional resources in schizophrenia and shared decision making.
Thank you, Nicole. I appreciate that. With a couple of minutes remaining, we can do a quick round of last minute suggestions, quick words of advice or inspiration for those who are in the caregiving trenches. Dr. Reggoratre, sorry.
It's such a tongue twister.
Anything last from you on your end?
No, I mean, things that just came up. I am reminded sometimes working with a provider who's had a lot of experience with all the different long actings. So Maria, I will say a little known fact, sesame seed oil is used as the base in haldol-decanoate, which is an old, came out I think in 1981. So it's been around forever. And so for some of my patients who are more interested in plant-based medications, this is not a drug that's, new. It doesn't have drug reps or anything. This is a generic medication that works really well. And I've had success when patients come to me and say, I'm only going to work with something natural. Well, I happen to know what the base of that one is, and patients like that. So sometimes just having that knowledge base and being flexible. If anything else, walk away and think it isn't all or nothing. We're just looking for flexible thinking for us as caregivers or providers and for the patients. We're wanting to accommodate what they need. And there are more options than you'd think out there.
Thank you. Maria or Christy, anything last from your caregiver perspective?
I think just following up to what she said, I think today isn't about saying we have to do these long acting medications, but we're showing and showcasing how helpful they are. I know that after my daughter was stable and, she was aware of what was going on, she didn't want to do long acting injections because she doesn't like shots. So I was fine to let her stay on the pills because she was compliant, right? And so I think it's just, it's an individual decision between the person and their caregiver. But I do think that it's important that caregivers step up to the plate and advocate as much as they can for that person and for their family overall. Because let's face it, these things, whether it's substance use, SMI, severe mental illness, it affects the whole family.
Thank you. In an interest of time, I am going to stop us there because I want to be respectful of those participating here and also joining. Thank you for everyone for an incredible discussion today. Also, thank you again to our supporters and partners at Teva for making this possible today. We will be making this recording available and on demand at caregiveraction.org. You see on your screen a range of ways you can connect to us on social media through our caregiver help desk. All of our resources are free and available to caregivers across the country. Thank you again so much for this important conversation, and we look forward to continuing it in the months and years ahead. Thanks, everyone.
Thank you.